We'll get started. A big welcome to everybody that's joined us this evening on what is World Lupus Day, the 10th of May. And that indeed is why we're having this webinar on the topic of lupus this evening. My name is John Hopkins and I'm the Chief Executive in Arthritis Ireland. And joining me tonight is Dr. Laura Durcan, who's a consultant rheumatologist at Beaumont Hospital. She is also an Honorary Senior Clinical Lecturer at the Royal College of Surgeons. And Laura also has completed a lupus scholarship at John Hopkins University. So thank you so much, Laura, for joining us here this evening on World Lupus Day. And a warm welcome to everybody that's joined us online as well. So just before we get started and we get into the questions, just want to go through a few housekeeping matters. In a few moments, I'll start the interview with Laura. And if you have any questions to put to Laura, during this evening's event, can I ask you maybe to note them down first? And then if they're not covered as one of the questions that I'm going to put to Laura, you might like to put it in the Q&A box, which is at the bottom of your ribbon of the webinar there. So if you insert it into the Q&A box, and then we'll do our best to answer as many of your questions before we finish tonight's session. Okay, so hopefully that's clear for everybody. So Laura, I'm just going to start off with the first question of the evening, and I suppose it's a fairly straightforward question for the topic of the night, which is, what is lupus? Are there different types, and can you tell us a little bit more about that, please?
I actually wish that was a really straightforward question.
Yes.
So I suppose first I want to thank Arthritis Ireland for taking on some of the, putting some visibility on lupus. I think it's a hugely important area. We haven't had anyone doing that. I'm really grateful to you, Grania. This is a phenomenal opportunity. Thank you. So firstly, I suppose lupus, I'm going to focus mostly on systemic lupus. So systemic lupus is lupus where you have evidence of immune dysfunction, which would be blood tests which show antibodies or suggest the presence of antibodies, and then organ damage or inflammation associated with that. So patients who have systemic lupus will present with, generally speaking, abnormal blood tests, and then they'll have clinical features suggestive of lupus. And when you're trying to diagnose systemic lupus, there's about 1,000,001 different ways that it can present. But generally speaking, the patients will have clinical symptoms with blood tests suggestive of lupus, and the combination of those will lead us to a diagnosis. Some people might present with, say, for example, cutaneous lupus, which is skin involvement. They'll present with a rash, it's been biopsied by a dermatologist, and they will then come to me because they may or may not have blood test abnormalities that go along with that. And my job is to diagnose the lupus and then to look and see what organs are involved and to tailor the treatment accordingly. Generally speaking, when lupus is, I suppose, localizes itself to the skin, I'm probably not going to focus on too much today because they're usually really well managed by dermatology. Most of what I talk about today will refer to kind of systemic lupus. So those are patients who have systemic involvement associated with their lupus. So say, for example, these patients, when they present to me, Grania, they could have, say, arthritis. This usually involves the small joints of the hands and feet. They'll have early morning stiffness. It gets a little bit better as the day goes on. And it might look a little bit like, or a lot like in some cases, rheumatoid arthritis. Some people will present with the skin disease, like I said. Other people will present with kidney involvement. So they'll present with swelling, where they're holding on to fluid. They'll come in with kidney failure or perhaps high blood pressure. Other people present with nerve symptoms, where they present with, different types of nerve abnormalities reflecting inflammation in their brains. Other people can present with clots as their first kind of clinical manifestation of lupus, where they have, say, phospholipids, which are pro-clotting blood tests associated with their lupus. And sometimes that's an opportunity for us to pick it up. And really, there's about 20 different overlapping kind of antibodies and clinical scenarios that bring us to the diagnosis. And if you're going to kind of go by, I suppose, the rule book, there's clinical criteria, and they require four criteria for a diagnosis, but it's generally, some of them are evidence of immune dysfunction, and some of them are clinical manifestations, and we marry those to come up with a diagnosis. And then in terms of how we approach that, it should be a patient-centered and specific kind of treatment regimen according to what organ or what manifestation that patient has. I hope that answers your question. That was very long.
So is it quite it sounds like there's lots of different manifestations of lupus. Does that make it very hard to diagnose? I mean, you mentioned there just earlier on in your answer, you know, that it can sometimes look a bit like rheumatoid arthritis. So as a clinician, is it really hard then to arrive at a diagnosis? Does it take a long time in lots of cases?
So in my world, like, you know, there was like a Dr. House quote of, oh, it's never lupus or whatever. So in my world, it's actually always lupus. So by the time, I suppose, so I'm a little bit biased. We know that it's, you know, less than 0.5% of the population. We know that it's 9 times more women than men. And we know that for the most part, although it can happen later in life, it's women in their teens, 20s and 30s where this kind of first brings itself together. And they are people who are, who can have a difficult journey coming to a diagnosis. And definitely there are some people who have had lots of symptoms for a long time before they got to the right doctor. On the flip side of that, Grania, if you have a diagnosis of lupus, you could have a broken leg and somebody would say that it's probably your lupus. So I'd say my patients have difficulty getting to a diagnosis. Once they have a diagnosis, they have difficulty with people will attribute everything they ever have to the diagnosis of lupus on the one hand. And then the third thing that they have is that people are kind of frightened of them and they don't want to treat them. And in the worst case scenario, they throw high dose steroids at them pretty much every time they see them. And I suppose those are like my four, the four kind of commonest problems that my patients have are A, getting to a diagnosis, and then B, having people listen to them when they have other things wrong with them can be a big challenge because obviously lupus can affect every organ. So there is sometimes this thing that no matter what you're complaining of, it must be your lupus. And that's a big challenge for patients.
Actually, just to follow on from that, how do you advise patients to navigate that? You know, when they get to you and they have a diagnosis, you know, in terms of, if you like, because it sounds like a patient would really need to be a strong advocate for their own health condition, for their own healthcare in order to manage this.
Like, I would say that I'm really lucky because most of my patients are really well informed about their condition because they have to be. So they seek out information. And they will usually have a really good handle on how it is themselves. I suppose lots of them will have comorbid fibromyalgia. And I think it's really important that fibromyalgia pain isn't attributed to lupus and treated with immunosuppression or high dose steroids because that's really harmful for those patients. And then the other bits, it's just about a systematic approach. And I think it's the same for the patients. You know, if it's predominantly arthritis, we treat the arthritis the same way we would treat rheumatoid. If it's nephritis or kidney inflammation, we treat the nephritis. If it's skin inflammation, we treat the skin inflammation. And sometimes, Grania, people will have combinations where they have skin plus kidney or, you know, joint plus, say, nervous system involvement. And truthfully, we pick probably the most serious of the manifestations and we target that, but the treatment will then cover the other manifestations. So it's a real kind of organ-based or systems-based approach to treating the lupus. And most patients kind of understand that.
So I just want to bring you back to something you mentioned just in one of your answers there about who is at risk of developing lupus.
So everyone.
Everyone, yeah.
So we've 9 times more. So generally speaking, patients who come to me will be in and around their teens, 20s, 30s. There is a second peak in elderly people, but for the most part, I see young people presenting with lupus. And often they're previously healthy and have never had a flag in terms of healthcare in their whole lives. And they come in with whatever this is. We know that smokers get more lupus and that they respond a little bit worse to therapy. So I'm really keen to get my patients off cigarettes. There is a family history component. So about somewhere between 30 to 50% of your risk of developing lupus comes from your family history, from your genetics. But it's not, Grania, like one gene that you get passed from your mother, from your, you know, it's the multitude of genes that you've been given. And it's how they interact with your environment. So some exposures that you have over your life can definitely trigger the development of lupus. So certain viruses, say like EBV, which causes mono or glandular fever. Some people get a big immune surge from that and that can trigger lupus. Other times it can be something as simple as a really bad sunburn. So if somebody has a lot of ultraviolet exposure, that has a huge stimulatory effect on the immune system. And some people it'll be sun exposure. And loads of other people, it'll be just like God knows what, you know, hitting menopause does funny things to people's bodies, but equally puberty does funny things to people's bodies. And we see lots of kind of immunologic changes as people go through puberty and as they grow up. And in particular, in women and young girls, you can see autoimmune disease starting to kind of take shape at that stage.
And in terms of the gender divide, is there one?
Yeah, so it's 9-1. So I have lots of very lovely male patients who come to my lupus clinic, but the vast majority of the people who come to lupus clinics are women. And I suppose I feel very strongly there are also lots and lots of non-Caucasian women. So more women who have brown skin or are of other ethnicities to Caucasian will get lupus, and they'll get worse lupus than those of us who are Caucasian. And so, like, I feel like that there are so many health inequalities across this. Like, I feel like as a feminist, I want my patients to get the best, and I really want to advocate for them. But I also want to make sure that there's no health disparities for people who are perhaps coming here from other countries. Maybe they're refugees, and lots of people. We now live in a completely multicultural society, and so my lupus clinic is full of people from all walks of life, and increasingly they're arriving from sub-Saharan Africa. I'm getting people from all kinds of really cool and interesting places who are coming with complex autoimmune diseases. And so again, I'm really happy that you're talking about this, because I think it's really important. These are the time of their lives where they should be generally at their peak healthiness. It's the time of their lives where they're having their babies. It's really important times in people's lives where lupus in particular hits, and it's a massively impactful disease for those people. And I think that if we do a good job of this, they lead wonderful and completely normal lives. But if we do a bad job of it, they end up on dialysis, they get kidney failure, they get cardiovascular disease, they get premature death. We do owe it to them to do a good job.
It sounds as well as Ireland's society and the makeup of our society has changed over the last few decades and will continue to change. It sounds like, that's going to present challenges and the greater need for example, better lupus care and better understanding and awareness of this disease as well. Would that be fair to say?
Absolutely. Yeah, 100%.
So I think we've covered off some of the questions I was going to ask you, but my next one really is around the treatments for lupus. And I know that obviously that's really evolved and developed in the last number of decades. So can you bring us through sort of, how a person might be treated and the treatments that are involved?
So Grania, I'm going to start with hydroxychloroquine. So this is Plaquenil. So this is the medication that Donald Trump wanted us to all take for COVID. And actually during that time, my poor lupus patients couldn't get for their lupus because people
shortages.
Yeah, exactly. So it doesn't do anything for COVID, but it is a really great lupus drug. And I would consider it to be the cornerstone of the medical management of lupus. And so if somebody comes to my clinic and I'm making a diagnosis of lupus, I will start them on hydroxychloroquine unless there's a very convincing reason why I shouldn't. So it's a weight-based medication. So if you're generally speaking 60 kilos, if you're below 60 kilos, you should be dose reduced. Above 60 kilos, you go on the standard 400 milligram dose. The only issue that I would say is that while people are on hydroxychloroquine, it's recommended that they have a yearly eye screen to make sure that they don't have any deposition at the back of their eye. But generally speaking, it's non-immunosuppressant. It's really well tolerated. It comes originally from a cinchona tree, which is the same place where people made tonic water. So it's got a slightly bitter taste. Sometimes people can find it a bit acidy in their stomach, but generally speaking, totally fine. Take the 2 pills together first thing in the morning and forget about it and move on with their lives. In terms of how it works, we actually don't really fully understand it. It has a kind of, I call it like fairy dust. It has a really subtle immune modulatory effect without causing overt immune suppression. And it's a great drug for those kind of inflammatory arthralgias. We often use it in rheumatoid also, but those kind of stiff, sore hands, they respond quite nicely to hydroxychloroquine. Skin disease in lupus responds really nicely to hydroxychloroquine. And then there's loads of data that as you go through your lupus journey, being on hydroxychloroquine prolongs your life, but it also prevents manifestations from occurring. So that patients who are on hydroxychloroquine for a duration of time have fewer kind of new manifestations which pop up a little bit like mushrooms on the lawn. So I would consider that. I consider it almost like a lupus multivitamin. And if anybody comes to me with a new diagnosis, that will be most likely the first prescription I write. I don't think it's possible to have a discussion about any lupus therapies without talking about prednisone. So that's corticosteroids. So most patients at some point in their lupus journey will end up with corticosteroids for some manifestation of lupus. Steroids are really great at immediately dampening down inflammation, but they come at a cost. So we know that a lot of the damage that our patients suffer from over the course of their lupus can be attributed to corticosteroids or steroid-mediated damage. So steroids increase your risk of osteoporosis, and they increase your cardiovascular risk, they increase the risk of infection, they cause obesity, they cause hypertension, they cause type 2 diabetes. And although patients get quite a significant boost from them in the shorter term, coming off them and dealing with the consequences of chronic steroids can be quite devastating for them. So I'm always very judicious in the use of steroids. I do often have to use them, say for severe inflammatory disease, but I'm careful with my steroids because I know, please God, that in 10, 15 years, I'll be looking at that person with their vertebral collapse, and I will be looking at them with regret. And so I'm very judicious with the use of corticosteroids in lupus, but some patients do end up on low dose steroids for a period of time, sometimes for a prolonged period of time. And it's a quid pro quo for those patients. You have to balance up the risks and the benefits. But steroids are there, and they do, in higher doses in particular, cause massive damage to my patients. So I'm careful about steroids, and I do ask my patients to be very judicious about the steroids, that doses that they take and they give. I suppose then I'm going to move on to say manifestation specific treatments. So if you have lupus arthritis, so if you have inflammation in your hands, just like swelling across the knuckles, pain and stiffness, this is treated almost entirely like rheumatoid arthritis therapies, with the exception that the biologics we use for rheumatoid aren't generally used in lupus. So things like methotrexate, which is a weekly medication that we use for arthritis, that would be quite commonly used in lupus. Things like cilazapyrine, sulfasalazine, we can use that. And then other kind of step-like progression through the arthritis medication, if it is arthritis, is a predominant manifestation. There's an interesting type of arthritis that happens in lupus that actually isn't steroid responsive or therapy responsive. And it's a thing called Jacquard's arthropathy. And that's where you get quite a significant drift at what's called the MCPJs. So the hands tend to drift to one side. And so the hands can look completely like a rheumatoid hand, but the difference is that there's no bony damage. So it's all ligament related. And so they can be pushed back into place, unlike a rheumatoid arthritis hand, which is generally stuck. So what it's worth noting is that if somebody has Jacquard's, which is a ligament drift in their hands, that isn't something that responds to standard arthritis therapy. And it's just worth noting whether or not the patient has inflammatory arthritis, which will be something that responds to immunosuppression, or Jacquard's arthropathy, which is a ligamentous drift in the hands relating to chronic lupus, and is a different entity altogether. In Jacquard's, the X-ray will not show any erosions or damage, whereas in rheumatoid, the X-ray will show lots of erosions and damage. So it's quite an easy one to kind of balance out.
And is there a treatment for that though?
Jacquard's?
Yeah.
No, and you know, Grania, it's very rare that the Jacquard's is actually disabling. It's more than see it. So like the hands, they kind of drift to the side. You can pull them in again. They're very loose at the metacarpophalangeal joints, but truthfully, they don't really hurt. They just look a little bit funny. And most people, if the worse that it gets, they might need a little bit of splinting to bring it back into malalignment. But truthfully, from a functional perspective, they work just fine usually.
Okay.
Now, so the arthritis is similar to rheumatoid. The skin disease, again, we immunosuppress skin disease. Sometimes the dermatologist will inject discoid skin lesions. So I think it's impossible to talk about skin disease in lupus without discussing hair. So patients with lupus, obviously, we're talking about a predominantly female population. Lots of them have hair problems. And this seems really trivial to be discussing, but it actually is really important in people's lives. So there are a couple of different types of lupus, alopecia or hair loss. So the first is relates to lupus kind of disease activity. And that's kind of general hair loss around the frame of the face. It looks a little bit like what people get when they've had a telogen effluvium, like when you've had a baby and the front of your hair kind of thins out. So patients with lupus will commonly get a kind of chronic version of that, where they have thinning of the front of their hair. it's generally not very severe, but it is a kind of a sign of chronic lupus, and it is something that we'd remark upon in the clinic. The other type of hair loss that people get is from discoid lupus. So discoid lupus, like the word says, disc, they're circular lesions, and people get patches of hair loss. Now, the problem with discoid is that discoid lupus is quite deep, and often it will damage the hair follicles underneath. So it's common that it can scar and the hair won't grow back if that happens. So we take discoid quite seriously. Dermatologists will often inject it with steroid, and we will immunosuppress people if they have discoid lesions on their head. The primary reason for discoid, though, is obviously that they have an immune abnormality, but it's ultraviolet exposure and smoking are two huge things with discoid. So anyone who has lupus, I really, really beg them to avoid sun exposure, factor 50, big hat. But in particular, if they have the scarring discoid, they have to absolutely avoid the sun, because those ultraviolet rays are a massive trigger for skin inflammation. If they are smokers and they have discoid lupus, we know that blocks the medication from working. And so we will beg those patients to get off the cigarettes in the hope that their skin will settle down. Nephritis has a whole different kind of list of therapies, but mycophenolate mofetil is usually the first line therapy. Some patients who have very severe nephritis will be given chemo in the form of cyclophosphamide. And both of those therapies are equally effective. So we usually go with mycophenolate first, unless there's a very convincing reason not to. And then if that fails, oftentimes we'll use rescue cyclophosphamide. We used to use very high doses of cyclophosphamide in lupus nephritis, but more recently we're using much lower doses. And patients used to be very kind of, I suppose, frightened about cyclophosphamide, but certainly from my perspective, I've had really good outcomes in the patients I've used cyclophosphamide on. And oftentimes it's just, we have to dampen down the inflammation so that these people can move on with their lives. And it's a short span of kind of feeling a bit grotty while you're on it. And then you get your life given back. So it's a really great medication for the people who need it. And I suppose then, listen, other organs can become inflamed. We immunosuppress those patients, and it will usually be either mycophenolate, sometimes azathioprine, and sometimes cyclophosphamide. And each kind of person's regimen is tailored according to what manifestations they have and what medications those respond to. And you kind of hope, Grania, that you get like a 2-for-1 or a 3-for-1, that you can get one medication and that it covered the umbrella of all that is bothering them.
So really a lupus patient will be on a combination of therapies depending on.
No, so you actually, you would think that, but actually most of the time, well, hydroxychloroquine in the background, but most of the time we squeeze it to get value for money. So most of the time they will be on one. Mm-hmm. Covers a myriad of manifestations. So most of the time, try your best to neaten it up. So you minimize, so they're on the bare minimum amount of medication, you minimize the side effects and hopefully get their disease really tightly controlled.
Okay. In terms of, daily life with lupus, what advice do you have for people living with lupus?
So I suppose the first thing, and this is going to sound harsh, but the biggest predictor of people's successful therapy is adherence with their medication. So if somebody comes to me and they have nephritis, one of the biggest predictor of how they will do from their nephritis is that they put their pills in their mouth, they take their tablets, and that they come to their appointments. And I would say that at least more than half of any poor outcomes that I've ever had in lupus, there's been a huge issue with getting the pills into the patients. And sometimes that can be because they make them feel unwell. And sometimes, but we can usually get around the kind of individual barriers. But often if somebody does badly from lupus, there's often been an issue with their medication. And I'm really keen at the very start to let them know that they should do really well. I expect them to do really well, but they do have to take their tablets. And loads of the studies. So when I was at Hopkins, we did some studies on looking at blood levels. And Grania, about 40% of the prescriptions we write never go to a pharmacy. They never go into a patient. They, and like I acknowledge that it's totally fine. I find it really hard to be compliant with anything myself. I totally get it. But I really want my patients to do well. So I would say the first thing I would say is, look, take your tablet. Then the second thing I will say is find your triggers. So ultraviolet exposure is a huge trigger for some people. You know, other people, it will be completely random and they can't predict it. Some people, it'll be that they can't get down off their steroids, and once they get down off their steroids, something flares up again. But usually they need more immune suppression. I really am keen for my patients to have completely normal lives. Like, I want them to have babies, I want them to have jobs, I want them to have holidays, I want them to have a normal life. So I suppose I do talk to them about pacing themselves, about being kind to themselves, and about finding what works for them. And that's totally different for each person. So there is a very individual component to this, and it's completely different for each person and their experience, in particular of fatigue and how much energy they have and how much they're able to take on.
Yeah, I was going to ask you about fatigue, because that's one of the things I hear, you know, a lot, is about that word fatigue, and just the struggles that people have with it. And that, you know, a lot of people say, well, it's actually worse than some of the other manifestations of the disease, because it can, you know, it can rob you of a normal life. Have you any advice for people as to how they might manage fatigue?
So the first thing that I will say is that the fatigue that my patients with I think fatigue is a really bad word. I think there should be another word in the English language to describe what they're experiencing. Because when
people who don't experience fatigue think, well, it's just tiredness. And anyone that really experienced fatigue said it's not just tiredness. But so yes, another word would be good.
Yeah, because I think that they say, they try to explain this horrible dead feeling that they have, where they can do literally nothing and they can't lift their bodies so they can't do, you know, they just can't. And I think when they describe that to other people, people hear it as, I'm tired. And obviously tiredness is ubiquitous, like we're all a little bit tired, but that's completely different to the fatigue that people with autoimmune disease experience. And so I suppose the first thing that I would say to them is that it is different from the fact that people say to you, oh yeah, you have small children, of course you're tired, or oh yeah, you have a full-time job, of course you're a bit, that, like, I don't know how to best explain this to people other than to say that the fatigue experience for people with autoimmune disease is completely different to normal life. And I think they have to explain that to their families and the people around them, because I think that's only fair. And I think it's also so that they don't get that back at them, you know. In terms of the answers for fatigue, they're also really difficult. So in most autoimmune disease, the first step in that kind of dead fatigue is making sure that you have control of the inflammation, because some of that dead feeling can be that your immune system is using all your energy to fight you, and that makes you feel terrible. So the first thing that you have to do is get control of that inflammation. So in rheumatoid, it would be get control of the joints. In lupus, it could be other manifestations that you have to get control of. So the first thing is kind of tightening up your disease control. We know from the rheumatoid literature that even with tight disease control, you have an impact on fatigue, but you don't take it away. And patients still complain, even with really tight disease control, of this kind of deadening fatigue. So then you have to look at the other things that impact in on that fatigue. So the first is, I suppose, sleep quality. And we know that our patients sleep really badly, and that if they are getting bad sleep, that they feel terrible. But that's not an easy one to solve. So the sleep issues are huge. There are some patients who won't get through the day without a nap. And I suppose the only thing that I say to them, Grania, is that if you're going to nap, it has to be a cat nap. What happens when you sleep for, say, longer than an hour, 90 minutes in the middle of the day, is that your brain hits REM, and your brain will only let you do that once. So if you have a big deep nap in the middle of the day, you will not sleep that night. And that cycle of negativity will continue. Yeah. So it has to be an alarm set at 20 minutes. And at 20 minutes, even if you feel like you're going to die, you have to get out of the bed. Then there's the scheduling stuff. So it has to be, and this is so boring, and I feel really grim even talking about it. It has to be, we schedule ourselves like babies. You have to go to bed at the same time every night. You have to get up at the same time every morning. There has to be an alarm set in the morning. There has to be no screens in bed, no reading in bed. If you're getting up to go to the loo at night, you should drink no tea or coffee during the day, and you should also not probably drink any fluid after 6 o'clock. Minimize your caffeine intake to make sure that you have it all before 11 o'clock in the morning. And yeah, make your bed literally be up until you go to sleep. And when you go to sleep, make it be that you sleep in your bed, and that we just train ourselves like you would a 6-month-old. And it works a little bit. It is worth doing because it does improve sleep quality. And that latency phase where you're trying to get to sleep definitely improves with that. So that's the first step. Second step is getting up your cardiovascular strength, and your kind of physical activity definitely helps with it. But I know that people really struggle with this. So I'm saying this, and I want to acknowledge how difficult this is. So getting up, and it's not really even the cardiovascular stuff, like getting up your physical activity over the course of the day. So I love when my patients wear an activity tracker so they can get an idea of their step count, but I also love it when they start taking on other types of exercise, Grania. So I really like it when my patients start lifting some weights, building a little bit of muscle. You know, the steroids, they'll have had, you know, really hard health time, and they'll have no muscle mass. And I love to see them kind of lifting a little bit of muscle, you know, looking after their diet, getting a bit of exercise. And it doesn't have to be endless walking of the dog, because that's boring. But like 10 or 15 minutes of weight-bearing exercise, in particular for women, building up their upper body strength is so important. But getting something where they're doing some physical activity during the course of the day really does help their sleep. And then the medications that people will prescribe for chronic pain and for sleep, I sometimes prescribe a little bit of amitriptyline at night, but I rarely prescribe Lyrica or the gabapentinoids, because I think that, well, they have a huge effect on people's appetite, their weight, and they make them foggy in the head. And I don't really buy that they make their pain that much better. So I personally would be slow to take a medication that made me gain weight, made me foggy in the head. So I'm pretty slow to prescribe those, but they are there, and they do certainly help, say, in chronic pain like fibromyalgia. But they come at a cost. They're not for free, and so they wouldn't be my first port of call. I'm probably losing track of myself now. Fatigue. We're still talking about fatigue. Yeah. So yeah, I think it's a tough one, and sometimes people will do everything right, Grania, and they'll still be absolutely flat. And all I can do for those poor devils is commiserate. There is a little bit of data around a medication called DHEA, but it's a version of a male hormone that gives some people a boost. I don't really describe it, but some people do take it. But it's a really, really tough one, and I don't have any easy answers.
You mentioned there about, you know, sort of the role of exercise and diet as well. And I mean, that always, I think those questions always get asked when it comes to, you know, autoimmune diseases in general. It certainly gets asked in arthritis, but I presume as well in terms of lupus that they're also important parts of a person's kind of overall approach to their treatment.
Oh yeah, but it isn't. Again, I wish that there was some diet that would turn off inflammation in the system, and there isn't. So I think that, you know, that all goes back to the boring stuff again, where it's like, you know, a good diet with lots of colored veggies and, you know, just the good stuff. But there isn't, like, there's no evidence for, say, gluten-free. There's no evidence for paleo. There's no, you know, there's no kind of fad diet that actually will give us any line of sight on disease control or immune activity. Patients ask me a lot about supplements. So most supplements are completely harmless, but I don't like them to take, say, John's wort, which goes through the liver and causes abnormal LFTs. It always interacts with medication. I don't want them taking that. I don't like them taking echinacea because that has an immune stimulant in it. And really any medication that comes with like an immune boost. So those ones that say they fight colds and flus or whatever it is, I don't like my patients taking that because their immune systems are already boosted. They don't need any further immune boost. But other than that, most of the over-the-counter, say, vitamins and that kind of stuff, I'm fine with those. I don't think they do a whole lot, but they certainly don't have harm. The one vitamin I do give patients is vitamin D, so I make sure they're replete with vitamin D, and that's mostly because if they can't see the sun, well, already we live in Ireland, we're all absolutely exposed to the sun, you will require a vitamin D supplement.
Yeah. I think one of the things we always say to people as well, you know, supplements and everything is ensure that you disclose anything that you're taking to your medical practitioner, even if it is something you're buying over the counter, because it is really important to be open and transparent about everything that you're taking. 100%.
Yeah. Exactly. And generally people come in with their little bottles, and generally, you know, there's no harm in the vast majority of them, but some of them do have harms, and you do have to tell people. Yeah, absolutely. I totally agree.
So moving on, look, this next question again is a hard one, and it's one that I know I'm sure you get asked all the time. And given if you like, the the prevalence amongst women and the prevalence of the disease amongst women of childbearing age as well. You know, I'm sure a key question you get asked is, can I have a baby if I have lupus?
Yeah, that's actually my question. So about like as recently as kind of 20 years ago, women would have been told that they shouldn't have children when they have lupus. And there was a lot of what we call, aside from people being told they shouldn't, but elective childlessness amongst lupus patients, because they had a perception that they couldn't have babies. And so they chose not to challenge that kind of paradigm and chose not to have babies. And so in the United States, where I worked, a lot of the lupus patients, it was recommended for them that they have terminations when they presented pregnant to the lupus clinic. And that wasn't that long ago. And so in my world, the conversation that I have with a woman with lupus who comes in to talk to me about her plans for babies is firstly a really exciting one. But I also love thinking about how far medicine has come and how cool it is that I'm having that conversation, and that in the vast majority of cases, how nice it is that I'll get to meet her baby at some stage. It might be a rocky path, but that at some point, the vast majority of people have successful pregnancies and they bring home gorgeous little babies. I love meeting those babies. So I do love that conversation. There's a couple of things I'm gonna highlight, because it's actually an endless conversation. I could probably talk all day for it. They do need to be managed in a high-risk obstetric clinic, so maternal medicine clinic. They do need to be managed there. Lots of them have Rho antibodies. So the Rho antibody associates with the small number of patients having what's called congenital heart block. So they need to be monitored for that. Hydroxychloroquine decreases the risk of congenital heart block, so I continue it in all lupus pregnancies. The other questions that need to be asked is whether or not the patient has phospholipids or a diagnosis of antiphospholipid syndrome along with their lupus. And that's whether or not they have a clotting problem with lupus. And if they do have a clotting problem, or if even they just have blood tests that demonstrate the possibility of a clotting problem, then most of those patients will be put on blood thinners for pregnancy. The vast majority of those blood thinners will be started once you have the blue line on your pregnancy test, rather than preemptively. If you're already on blood thinners, say for example on warfarin, and you're planning a pregnancy, you can either be swapped to low molecular weight heparin at the immediate, these are planned pregnancies, so presumably you'd find out pretty early that you're pregnant. So you can either be swapped very, very early in pregnancy to injections, or you can elect to go on to injections whilst planning the pregnancy. And you don't stay on warfarin for pregnancy, you change to a different, usually low molecular weight heparin injections. And then those patients, generally speaking, screen for Rho, regular follow-up in the maternal medicine clinic, figure out their coagulation. And if they require immunosuppression, it's usually Imuran or azathioprine that they're prescribed. And that's because that medication does not go into their babies. So Imuran, the babies lack the enzyme for metabolizing Imuran, which is super handy. And so Imuran doesn't get put into its active form in the baby, and so is completely cost neutral in terms of pregnancy, unlike lots of our other medications, which we don't regularly prescribe in pregnancy. Azathioprine is great, can be dialed up and dialed down according to their disease activity if needed in pregnancy, and often gives us a lot of comfort as we go through a pregnancy that they have some form of immune therapy on board. The important thing for people with nephritis and kind of very severe systemic disease is making sure that their disease control is good prior to embarking on pregnancy, and then that they're really closely managed during pregnancy and monitored for the growth of the baby, fetal heart block, and then the presence of preeclampsia.
Right, so a lot to consider, but I guess the message there is, have a conversation with your consultant, with your doctor in advance of making any decisions around pregnancy.
100%.
Planning is key.
Yeah.
But it sounds like it's a lot more positive than it was several decades ago. So I think that's really a really important message to give out tonight.
I feel like honestly, my lupus clinic is a more fertile spot than most places. I feel like I get a lot of babies back at me, which is great.
Yeah, good. So we're moving towards the end now, and I'll just remind people, if they do have questions, to start putting them in the Q&A box, okay? Because we'll be able to take a few questions as we at the end. And Laura, one of my kind of wrap-up questions here is really what does the future hold for people with lupus in terms of new treatments on the horizons and new developments in this space? Can you tell us a little bit about that?
So Grania, I'm going to take the opportunity here for whoever's listening to kind of advocate here, because truthfully, my patients with lupus are either too young and busy to be in this space, or they're too sick and miserable. And so I feel like it should, and it does fall on me to say this. So there are medications that have been licensed for lupus for more than 10 years. And Ireland is probably the only country in the developed world where we don't have access to those medications. And without sounding like an absolutely militant feminist, I feel like if this was a disease that men got, it would be licensed. All of our ankylosing spondylitis medications are licensed. All of our arthritis medications are licensed. And this one medication for lupus has been sitting on the shelf for 10 years now, and I don't have access to it for my patients. I have patients who get it in Germany and come home with it. And I just find it incredibly infuriating. So that's the first thing. That's belimumab. That was the first new medication for lupus. There are anifrolumab. There's loads of new kind of biological agents that are coming online for lupus. I think it's going to be part exciting new medications, but I think it's also going to be part us figuring out who is going to get what, because at the moment I'm describing to you the biggest overlapping Venn diagram imaginable. And I think goes on, we'll get better at categorizing people into what type of lupus they have, but also what type of lupus they look like they're going to get, and what pathways they're on, and what we can expect to happen. And we know some of that, but truthfully, I think there's a lot to learn there. And once you figure out what pathway someone is on, then it would be super cool if you had medications that could stop those pathways. And you could say, right, well, you were heading straight for nephritis and I gave you this and it never happened, and happy days. And I would say that that would be a really great place to be if I could risk stratify and then prevent disease manifestations. And the new therapies are great. I haven't gotten my hands, I've used one of them in the States. I haven't gotten my hands on the other, because again, that's not licensed here. But I do think there's a little piece for us to do in terms of advocacy and making sure that our patients have access to medications that are licensed for lupus, because the toxicities of prednisone, which is what we use in place of these medications, are enormous, and the long-term consequences of chronic steroid use are harmful.
Okay, thank you. I think it certainly sounds like there's lots of positive things coming down the line. And I think when it comes to that whole area of autoimmune diseases, it's all kind of moving towards this precision medicine, isn't it? You know, in terms of, I should say, stratifying patient groups and actually then being able to treat them accordingly. So I think it's a really exciting space, and it's a positive, I suppose it's a positive way forward for the treatment of lupus. We've been asking people to post their questions in the Q&A box, and I'll maybe start with the first question I have for you here, which is, how often should you get your bloods checked once you get the initial positive test for lupus antibodies? No medication has been prescribed in my case yet.
Okay, so lots of those antibodies don't change over your lifetime. So say, for example, Rho antibodies, once you make those, they're just part of your body. They're made by plasma cells, really long living. They don't change. And actually the titer of those, whether they go up or down, is completely irrelevant. Their presence, it's a binary. You either have them or you don't have them. And truthfully, you don't really need to check those again. So I would say they don't need to be checked again. Some people will monitor, and we do a little bit monitor double-stranded DNA titers in people who have active disease. So the titers of anti-double-stranded DNA does go up and down in disease activity, and we do monitor those. And we monitor complement, which is C3 and C4, to look for disease activity. So those are markers of how much immune complexes people with lupus are making. And so we monitor those over time. We monitor kidney function, urinary protein, because we know that about 70% of people who have lupus over their lifetime will get nephritis. So we monitor their urinary protein. And truthfully, those bloods should be run every, to start with, at a new diagnosis, I run them every 6 months. But if someone is sick, I run them more frequently than that. And if someone is on immune suppressant medication, they get their bloods done according to how often they need to for those meds, if that makes sense.
Yeah, okay, thanks. Another question here. I have lupus, and my question is, should my daughter get tested for same? She has just had her first baby at age 39.
Well, congratulations. I love a good baby. So no. So unless she has any manifestations that would make you concerned that she has systemic lupus, I would not go testing unless she presented with pain and stiffness in her hands, a rash, a clinical manifestation, because what will happen is, Like, you know, at least 20% of us women will have a positive ANA. And this is going to create huge anxiety when you say, oh, she's got a positive ANA. But a positive ANA is going to mean very little really in terms of clinical manifestations. So if she's well and she's doing okay, I wouldn't dream of sending off a panel, because I don't think it's going to give you useful information.
Another question here. Can lupus cause bladder inflammation and bladder wall thickening? I appreciate cystitis is more typically associated with Sjogren's disease. So bladder inflammation and bladder wall thickening.
Yeah, so that's probably, so lupus and Sjogren's have massive big overlap, but that kind of cystitis-y stuff sits much more on the Sjogren's side of the spectrum. That doesn't mean that you can't also fulfill criteria for lupus and have Sjogren's and all of its manifestations. So I didn't even really mention Sjogren's, but you know, there's a huge overlap between Sjogren's and lupus, the same way there's a huge overlap between antiphospholipid syndrome and lupus. And so some of the manifestations that you might have might fall on the side of Sjogren's, and other manifestations may drift closer to the side of lupus. And that happens all the time. And truthfully, in rheumatology, we live in the grey zone a lot. And so we're usually pretty flexible with our categories.
Can you just maybe explain what Sjogren's is, just with the people? I know we're not talking about Sjogren's, but just the fact that it's been mentioned here now, just to even explain briefly what it is.
So Sjogren's is autoimmune. So it's an autoimmune dryness, usually associated with what's called a Rho antibody, which is found in lots of people who have lupus also. Clinical manifestations would include dry eyes, dry mouth, often parotid swelling, associated lymph nodes. And they often are quite sensitive to the sun with a Rho antibody, lots of sun-sensitive rashes. And so there's a big overlap between Sjogren's, blood test abnormalities, symptoms of Sjogren's, and lupus. So often women will be diagnosed with both, or sometimes will be diagnosed with one initially and then drift towards a diagnosis of the other, but there's a huge overlap between the two.
Okay, thanks for that. So what can patients take to ameliorate the side effects of steroids like osteoporosis?
So honestly, I feel like it is getting a better therapy than the first job is to see whether or not we can get a better immune therapy than the prednisone. So be it azathioprine, mycophenolate, and whether those are suitable therapies for whatever disease manifestations you have. That's the first question. If steroids are required in the longer term for your health maintenance, there's 2 or 3 things I think about. The first thing I think about is your bone health. So if you're taking chronic steroids, often taking a bisphosphonate is helpful in terms of maintaining bone density and preventing fractures. The second thing that I will say is that if you're taking chronic steroid of 5 milligrams or greater and you're unwell, you need to be stress dosed. So if you're presenting for an operation, you're on chronic steroids, you need to tell them you're on chronic steroids so that they stress dose you for an operation. And if you have a day where you're vomiting or you're unwell, you should take double the dose of your chronic steroids. And that's to prevent what are called iatrogenic Addisonian crisis, or episodes where your blood pressure goes very low and you feel totally miserable because your own adrenal glands don't have any kick. I suppose the other things then are risk of infection with chronic steroid use, and then the cardiovascular stuff, because there is a signal for cardiovascular disease in people who take chronic steroids. So things like blood pressure, making sure those are tight.
Okay. Now the next question I'm going to need help deciphering. Is there any connection between Dupuytren's contracture and other inflammatory diseases such as rheumatoid arthritis, Jacquard's, etc.?
So
is that pronounced, just so that
Dupuytren's. So Dupuytren's is thick fascia that pulls down the fingers.
Yeah.
So happens in people who have kind of abnormal, sometimes it happens just out of nowhere. It happens in some people who have abnormal mechanics in their hands. And so you've been using your hands in funny ways, maybe because of arthritis, you might see more Dupuytren's. But generally speaking, it just pops up. So more in people who use vibration tools, or if people have a heavy use of alcohol, you can sometimes see it in the hands. We don't do anything about it surgically unless it's literally pulling down the fingers and they're getting caught in things, because there's a big recurrence rate with the surgery. And so I try my best not to, but if it's really getting in the way, I send them to plastic surgery.
Right. So so the question really is about manifestations of lupus that affect the nerves. So can it cause autonomic dysfunction, neuropathy, and small fiber neuropathy?
Yeah, so small fiber peripheral neuropathy, I think, is probably the question. So most cases of, so that's so kind of numb and painful hands and feet, often in like a glove and stocking distribution. So they're numb in a kind of a bilateral symmetrical pattern. So I would say small fiber peripheral neuropathy in 95% of cases falls under the umbrella of idiopathic. So we often don't find a cause for it, which is really disappointing. The ones that we do find a cause for, diabetes is probably the most common cause. And after that, you can get small fiber peripheral neuropathies associated with lupus, but more in the Sjogren's spectrum. So it's more people who have a positive Rho antibody and fall in that kind of Sjogren's rather than lupus spectrum of disease. But that doesn't mean they can't also have lupus. And so I do sometimes encounter that. Very difficult to know whether giving those patients immune suppression actually alters the small fiber peripheral neuropathy. And generally speaking, in most cases, it doesn't, because once those nerves are gone, they're gone. The problem is trying to figure out who might have progressive neuropathy. And if we think it's progressive, then they should be immunosuppressed. So it's a tricky one for patients. And I don't know that even with immune suppression that we commonly impact in a positive way on their symptoms. It's a very tough one.
Right. Right. The next one is around, can you have systemic lupus with no positive antibody blood tests?
Not usually, no. So generally speaking, it's not really possible to squeeze the lupus diagnosis without there being some evidence of immune dysfunction. So some people may have Rho antibodies which don't, but they may not have strongly positive other antibodies, and they meet criteria for lupus. Some people can have autoimmune hemolytic anemias and other antibodies associated with that who may not be classically tested for antibodies. But generally speaking, the bloods will show some evidence of immune dysfunction for the patient to be appropriately classified as having systemic lupus.
Okay. And the next one, I'm sure, is a question you've got asked a million times before. And it's really about, in relation to drug treatments, in terms of how long do you give a drug for lupus a chance before you give it up and move on to something else? If it works a bit, should you risk the months it might take for another drug to work for you? This person has tried many, many drugs.
So the only, I suppose that is a very individual question, and there isn't an endless list of medication. And so oftentimes we end up kind of changing doses, adding in alternative agents, adding in different bits and bobs, because we don't have a long list of medication to choose from. The scenario where we have kind of clearest guidance on the literature as to how to escalate and de-escalate therapy is nephritis or kidney inflammation. And there's very clear guidance on what is deemed a kind of a renal response or success in kidney disease, and how to escalate the therapies according to how their urine protein creatinine is. So the only part of lupus that has very clear-cut guidelines around escalation and de-escalation of therapy is lupus nephritis. And essentially everything else we go by kind of, how the patient is tolerating the medication, how the patient is doing, what the clinician thinks of the patient, what the bloods look like. And it's a very kind of composite and almost ad hoc measure of whether they're responding or not responding. But nephritis has very clear-cut outcome measures, and I suppose we should probably look to replicate that in other areas. But truthfully, Grania, like lots of people have like 3 or 4 different domains that we're treating at any given time, and it can be really difficult to get a clear idea as to what's working for what. And like I said, there isn't an endless number of medications for us to choose from, so we do end up squeezing the meds that we have to try and keep patients controlled.
Okay, another question here is, can lupus cause low blood pressure?
So loads of my patients who have lupus also have low blood pressure, and generally speaking, reflects the fact that they're young and that they have, and that maybe in other scenarios they wouldn't necessarily be having their blood pressure tested lots of times. The patients in my life who have most problematic blood pressure issues are the patients who are hypermobile and have things that look a little bit like POTS, where they have very labile blood pressure and a heart rate, which changes with posture. It's not so much a problem with lupus, and more so in lupus patients who have nephritis, we have problematic hypertension rather than hypotension. So in terms of lupus, kind of say renal disease activity, etc., I'd be quite reassured by blood pressure being low. The issue is I would flag is if somebody is on chronic steroids or withdrawing from chronic steroids and their blood pressure is low, sometimes that can be a trigger, which would indicate that they are kind of withdrawing a little bit too quickly from their steroids. But I wouldn't have any concerns about blood pressure on the lower end otherwise.
For that. Now we're moving towards the end here, so just maybe one or two more questions. Can lupus cause cyclical neutropenia?
So cyclical neutropenia is by itself a separate and pretty well-defined entity. So people who get, and I kind of like these, this sounds ridiculous. I like cyclical neutropenia because my patients who have cyclical neutropenia, they tend to be really muscular and well-developed neutrophils that get left behind, and my patients don't run into huge issues with infections, even though sometimes their neutrophils can go quite low. And it's like, I always say that it's a little bit like having a really busy office with one person running it can sometimes be better than having 10 people who maybe are doing half the work of that one person who was on their own. So often those low newts do a great job of protecting from infection. It is worth in anybody who has cyclical neutropenia making sure that the lupus bloods are sent, just to ensure that that's not the underlying cause. But cyclical neutropenia is of itself a kind of a separate diagnosis.
Okay. Thank you. And actually that seems to be the end of our questions. Oh, well, we'll maybe just take this final one. It says, why are there so few lupus specialist rheumatologists in Ireland?
So honestly, I would say it's I'm gonna try and put this way. I'd say up until the last 15 years, there probably wasn't that much lupus, being totally frank. I think that people maybe didn't, I'm sure that there was a lapse in the diagnosis. I'm sure like there's definitely a lot more lupus in Ireland. Maybe we're better at diagnosing it. I can't explain it, but I suppose for a long time, I think in the rheumatology community, we were completely fixated on rheumatoid arthritis and on psoriatic arthritis. And I think it's only in the last few years that people have started to really engage with the connective tissue diseases. So yeah, we definitely do need more. But I think there's more in, I think that people are also in general much better at lupus than they were. And I think the care is really good. And certainly from an obstetric and renal perspective, you know, things have come along a lot, even since I've been home from the States, and that's only 6 years. So I do think the future is bright.
Okay, and on that bright, positive note, we might wrap up this evening. Thank you, Laura, so much for joining us this evening on World Lupus Day. We really appreciate you giving us your time. And I hope everybody listening found that really informative. I certainly did. And just to say to people that you can find more information on Arthritis Ireland services and supports on arthritisireland.ie.